Third chapter, urinary screening tests for inborn errors of metabolism. इनबॉर्न एरर्स ऑफ मेटाबॉलिज्म IEM, इसका मतलब क्या होता है कि जेनेटिकली कुछ एरर्स हो जाते हैं, जन्म से ही हो जाते हैं, ठीक है, तो जिसका कोई इलाज नहीं है, ऐसा कुछ ना। देखते हैं क्या है क्या नहीं, अगर इलाज है तो क्या है संभव। Inborn errors of metabolism IEM are a heterogeneous group of disorders first described by the British physician Sir Archibald Jarrod, whose work on alkaptonuria led to him coining this term. IEMs are caused due to a single gene defect which may manifest immediately after birth, within few days or week after birth, or even in adulthood. The gene defect result in abnormalities in the synthesis or catabolism of proteins, carbohydrates, fats, or complex molecules. Most are due to defect in an enzyme or transport protein, which results in a block in a metabolic pathway. Effects are due to toxic accumulation of substances before the block intermediates from alternative metabolic pathway. Defects in energy production and use caused by a deficiency of products beyond the block, or a combination of these metabolic deviation. Nearly every metabolic disease has several forms that vary in age of onset, clinical severity, and often mode of inheritance. All IEMs are all genetically transmitted, typically in an autosomal recessive or X-linked recessive fashion. Autosomal recessive or X-linked recessive fashion. The incidence of IEMs collectively is estimated to be 1 in 2,500 live births, but it varies greatly and depends on the population. Phenylketonuria (PKU), maple syrup urine disease (MSUD), and medium chain acyl coenzyme dehydrogenase (MCAD). Deficiency are some of the IEMs that are common. IEM causing clinical manifestations in the neonatal period are usually severe and often lethal. The newborn baby with IEM may present with neurologic or metabolic disturbance like poor feeding, lethargy, failure to thrive, seizure, apnea, drowsiness, coma, and later on there may be gross delay in the development of milestones. Therefore, early diagnosis of the condition by various laboratory tests and initiations of prompt therapy is very much essential. In order to prevent lethal complications which are irreversible, various simple preliminary laboratory tests can aid in diagnosis of IEM, which can be further confirmed by advanced diagnostic techniques like HPLC, gas chromatography, mass spectrometry. HPLC, gas chromatography, mass spectrometry, genetic molecular analysis, and tandem mass spectrometry (TMS). Gone are the days when individual tests needed to be done for diagnosis. Each IEM today, with a wide variety of TMS assay available. Tandem mass spectrometry. Gone are the days when individual tests needed to be done for diagnosis. Each IEM today, with a wide variety of TMS assay available, one drop of blood can help in diagnosis multiple IEMs at the same time. PKU, phenylketonuria. It is a disorder of phenylalanine metabolism. It is an autosomal recessive condition with an incidence of 1 in 10,000 births. Most commonly caused by mutation in the gene coding for the enzyme phenylalanine hydroxylase. Phenylalanine hydroxylase responsible for the conversion of phenylalanine to tyrosine. Classical PKU. Deficiency of the enzyme phenylalanine hydroxylase (PAH) or of its cofactor tetrahydrobiopterin BH4. Type 2, type 3, type 4 causes accumulation of phenylalanine in body fluids and in the brain. In the absence of this main reaction, alternate pathways predominate and byproducts like phenyl pyruvate, phenyl acetate, and phenyl acetate are produced in abundance. High plasma and urinary level of phenylalanine and its byproducts are seen. Normal blood level of phenylalanine is 1 mg per deciliter. In PKU, phenylketonuria, it may increase to 20 mg per deciliter or more. BH4 is synthesized from guanosine triphosphate (GTP) through several enzymatic reactions. In addition to acting as a cofactor of cofactor for pH, BH4 is also a cofactor for tyrosine hydroxylase and tryptophan hydroxylase, which are involved in the biosynthesis of dopamine and serotonin. Therefore, patients with hyperphenylalaninemia results from BH4 deficiency also manifest neurological findings related to deficiency of these neurotransmitters. Phenylalanine, PKU, tyrosine, albinism, dopamine, melanin, tyrosine, para-hydroxyphenyl pyruvic acid, para-hydroxyphenyl lactic acid, tyrosinemia, homogentisic acid, alkaptonuria, mallyl acetoacetate, phenylalanine, phenyl pyruvic acid, phenyl lactic acid, phenyl acetic acid. Metabolic pathways showing location of various metabolic blocks, their associated disorders, and elevated key amino acids and metabolites. Test for phenylketonuria. Experiment number 18. Ferric chloride test. To 1 ml of freshly voided urine, add 2 drops of ferric chloride solution and mix. Observe the color change immediately, and after 2 to 4 minutes, a blue-green color is seen, which persists for 2 to 4 minutes, indicates the presence of phenylpyruvic acid. Note: the ferric chloride test is not a specific for phenylketonuria and can give various color in different disease. Experiment number 19. Dinitrophenyl hydrazine tests. D and pH test. The reagents should be used at room temperature. Add 10 drops of D and pH dinitrophenyl hydrazine test to 1 ml of freshly voided clear urine. Mix and leave for 10 minutes. Mix freshly voided clear urine. Mix and leave for 10 minutes. The reagent should be used at room temperature. Add 10 drops of D and pH reagent to 1 ml of freshly voided clear urine. Mix and leave for 10 minutes. The presence of a yellow or chalky white precipitate indicates a positive reaction. The test indicates the presence of keto acids in the urine. The test indicates the presence of keto acids in the urine. Alkaptonuria. Alkaptonuria is a rare IEM disorder of tyrosine metabolism with an incidence of approximately 1 in 250,000 live births. एक्सपेरिमेंट नंबर 19 में क्या था? रिएजेंट शुड बी यूज्ड रूम टेम्परेचर एट 10 ड्रॉप्स डी एंड पीएच रिएजेंट टू 1 ml ऑफ फ्रेशली voided clear urine. Mix and leave for 10 minutes. The presence of yellow or chalky white precipitate indicates a positive reaction. The test indicates the presence of keto acids in the urine. Okay. Alkaptonuria. Alkaptonuria is a rare IEM disorder in tyrosine metabolism with an incidence of approximately 1 in 250,000 live births. It is an autosomal recessive disorder. It is caused by the deficiency of the enzyme hemogentisate 1,2 dioxygenase. Hemogentisate oxidase. It is caused by the deficiency of the enzyme homogentisate 1,2 dioxygenase. Homogentisate oxidase. The enzyme catalyzes the conversion of homogentic acid to malylacetoacetic acid. It leads to formation of large amounts of homogentic acid. Excess homogentic acid is excreted in urine or deposited in tissues. Tyrosine, phyli and protein synthesis. Tyrosinamia 2, 4-OH phenyl pyruvate. Hawkinson urea. Pterin, glutathione, Hawkinson, 4-OH, 4-hydroxycyclohexyl acetate. Tyrosinamia 3, homogentic acid alkaptonuria. Melyl acetoacetate. Fumarate acetoacetate. Tyrosinamia 1, fumarate acetoacetate, CO2 H2O. In adults, the main clinical manifestation of alkaptonuria consists of ochronosis and arthritis. Ochronosis, which is seen clinically as dark spot on the sclera or ear cartilage, results from the accumulation of black polymer of homogentic acid. The only sign seen in children is blackening of the urine on standing, caused by oxidation and polymerization of homogentic acid black colored captain bodies. A history of gray or black stained disappears should suggest the diagnosis. A history of gray or black stained diaper should suggest the diagnosis. High incidence of heart disease, mitral and aortic valvulitis, calcification of heart valve, myocardial infarction is seen in patient of alkaptonuria. Tests for alkaptonuria. Experiment number 20. Ferric chloride test. To 1 ml of freshly voided urine, add 2 drops of ferric chloride solution and mix. Observe for color change immediately, and after 2 to 4 minutes a blue purple color is seen, which indicates the presence of homogentic acid. Experiment number 21. Benedict's test. To 5 ml of Benedict's reagent, add 8 drops of urine, mix and boil it for not less than 2 minutes. The presence of a brown color indicates a positive reaction. The test indicates a homogentic acid may be present in the urine. Homocystinuria. It is a disorder of methionine. Sulfur-containing amino acids metabolism. Homocystinuria. It is disorder of methionine, sulfur-containing amino acids metabolism. Methionine metabolism का disorder है homocystinuria. It is an autosomal recessive condition with an incidence of 1 in 2 lakh births. Folic acid tetrahydrofolate FH4 N5-methyl F4 homocystinuria N5 and methylene for glycine serine tetrahydrofolate folic acid. Vitamin B12 CB1C DEF GJX methyl CBN homocystinuria. Methionine dimethylglycine sulfur adenosyl methionine sulfur adenosyl homocysteine methionine homocysteine betaine choline betaine dimethylglycine classic homocystinuria. cystathionemia, alpha ketobutyric acid, homoserine cysteine, pathways in the metabolism of sulfur containing amino acids. Normally, most homocysteine, an intermediate compound of methionine degeneration, is remethylated to methionine. This methionine sparing reaction is catalyzed by enzyme methionine synthase, which requires a metabolite of folic acid 5-methyl tetrahydrofolate as a methyl donor and a metabolite of vitamin B12 methylcobalamin as a cofactor. In healthy individuals, most plasma homocysteine is either protein bound or exists as disulfides. Three major forms of homocysteinemia and homocysteinuria have been identified. First, homocysteinuria caused by cystathionine beta synthase deficiency, classic homocysteinuria. Homocysteinuria caused by cystathionine beta synthase deficiency, classic homocysteinuria. Homocysteinuria caused by defect in methylcobalamin formation. Homocysteinuria caused by deficiency of methylene tetrahydrofolate reductase, MTHFR deficiency. This is most common inborn error of methionine metabolism. Type 1 homocysteinuria caused by cystathione beta synthase deficiency, classic homocysteinuria. This is the most common inborn error of methionine metabolism. Infants with classical homocysteinuria appears normal at birth. Clinical manifestations during infancy are non-specific and may include failure to thrive and development delay. This causes severe myopia and iridodonesis, quivering of the iris, astigmatism, glaucoma, staphyloma, cataract, retinal detachment, and optic atrophy may develop later in life. Psychiatric and behavioral disorders have been observed in more than 50% of affected patients. Affected individuals with homocysteinuria manifests skeletal abnormalities, the serious consequence of thromboembolism, which is likely caused by elevated homocysteine levels. Elevations of both methionine and homocysteine or homocysteine in body fluids are the diagnostic laboratory findings. Homocysteinuria caused by defect in methylcobalamin formation. Methylcobalamin is the cofactor for the enzyme methionine synthase, which catalyzes remethylations of homocysteines to methionine. Methylcobalamin is a cofactor for the enzyme methionine synthase. Methylcobalamin is the cofactor for the enzyme methionine synthase, which catalyzes remethylation of homocysteine to methionine. Patients with this defect are unable which catalyzes the methylation of homocysteine to methionine. Patients with this defect are unable to form methylcobalamin and develop homocysteinuria without methylmalonic acidemia. The clinical manifestations are similar in patients with these three defects. Non-specific symptoms such as vomiting, poor feeding, failure to thrive, lethargy, hypotonia, seizures, and developmental delay may occur in first few months of life. Laboratory findings include megaloblastic anemia, hyperhomocysteinemia, homocysteinuria, and hypomethionemia. Homocysteinuria caused by deficiency of methylene tetrahydrofolate reductase deficiency. This enzyme reduces 5 to 10 methylene tetrahydrofolate to form 5-methyl tetrahydrofolate, which provides the methyl group needed for remethylation of homocysteine to methionine. Clinical findings vary from apnea, seizure, microcephaly, coma and death. टाइप 3 में क्या है? होमोसिस्टीन्यूरिया caused by deficiency of methylene tetrahydrofolate reductase MTHFR deficiency. This enzyme reduces 5,10 methylene tetrahydrofolate to form 5-methyl tetrahydrofolate, which provides the methyl group needed for remethylation of homocysteine to methionine. Clinical findings vary from apnea, seizure, microcephaly, coma, and death to developmental delay, ataxia, motor abnormalities, peripheral neuropathy, and psychiatric manifestations. Thromboembolism has also been observed. Laboratory findings include moderate homocysteinemia and homocysteinuria. The methionine concentration is low or low normal. Tests for homocysteinuria. Cyanide nitroprusside tests. Test for homocysteinuria. Experiment number 22. Cyanide nitroprusside test. Reagent A, reagent B, reagent C. Reagent A क्या कहता है? 5% aqueous sodium cyanide. Reagent B 50% aqueous sodium nitroprusside. Reagent C 2N sodium hydroxide. 5% aqueous sodium cyanide लेना है, 50% aqueous sodium nitroprusside और sodium cyanide, sodium nitroprusside, sodium hydroxide, cyanide, nitroprusside और hydroxide. Reagent A and B should be stored in a brown bottle in the refrigerator. Reagent A should be made freshly each month. Both solutions are dangerous and require caution in handling and storage. With a pH paper, alkalinize 2.5 ml of urine with reagent C to between pH 6 to 8. With a pH paper, alkalinize 2.5 ml of urine with reagent C to between pH 6 to 8. Add 1 ml of reagent A to the urine. After mixing, let stand for 20 minutes and then add 1 drop of reagent B. Pink, red or beet color within 5 minutes indicates an abnormal urine. The urine reaction is given by compounds which possess a free sulfhydryl group or disulfide bond. Cysteine and homocysteine are therefore detected by the test, but cystathionine, methionine and taurine do not react. Test experiment number 23. Test for differentiate between cysteine and homocysteine. In a test tube, take 2 ml of urine and saturate it with solid NaCl. To this add 4 drops of ammoniacal AgNO3 solution and mix. Put the test tube on the stand to rest for at least a minute. Subsequently, add 4 drops of freshly prepared sodium nitroprusside sodium cyanide solution. The purple-pink color denotes the presence of homocysteine in the urine. If there is a development of purple-pink color after a delay, then the urine contains cysteine. Maple syrup urine disease, MSUD. Maple syrup urine disease. Maple syrup urine disease is a primary aminoacidopathy affecting branched chain amino acids metabolism. It is an autosomal recessive disorder due to the deficiency of the enzyme branched chain alpha ketoacid dehydrogenase BCKBH. Branched chain alpha keto dehydrogenase is the main enzyme in the catabolic pathway of branched chain amino acid. Decarboxylation of leucine, isoleucine and valine is accomplished by this complex mitochondrial enzyme system using thiamine pyrophosphate vitamin B1 as a coenzyme. This disorder, named after the peculiar sweet odor of maple syrup found in the body fluids, especially urine and sweat. Affected infants who appear healthy at birth develop poor feeding and vomiting in the first day of life. Lethargy and coma may ensue within a few days. Leucine and its derivatives alpha keto isocaproic acid appears to be the key factor underlying acute encephalopathy. MSUD is usually confirmed by doing an amino acid analysis, which shows marked elevation in plasma level of leucine, isoleucine, valine. An amino acid analysis which shows marked elevation in plasma level of leucine, isoleucine, valine, and allo-isoleucine, and depressed level of alanine. Urine is also seen to contain high level of leucine, isoleucine, and valine. And their respective keto acids. Test for the maple syrup urine disease. Experiment number 24. Ferric chloride test. To 1 ml of freshly powdered urine, add 2 drops of ferric chloride solution and mix. Observe for color change immediately and after 2 to 4 minutes. A green-gray color is seen which persists for 2 to 4 minutes may indicate the presence of MSUD. Experiment number 25. Dinitrophenyl hydrogen test. DNPH test. The reagent should be used room temperature. Add 10 drops of DNPH reagent to 1 ml of freshly powdered urine. Clear urine, mix and leave for 10 minutes. The presence of yellow precipitate indicates the positive reaction. The test indicates the presence of keto acids in the urine. Glucose 6-phosphate dehydrogenase deficiency. Glucose 6-phosphate dehydrogenase catalyzes the conversion of glucose 6-phosphate to 6-phosphogluconic acid in the hexose monophosphates shunt. This reaction produces NADPH, which maintains GSH glutathione in its reduced or functional state. As protection against oxidant threats from certain drugs and infections that would otherwise cause precipitation of hemoglobin, Hinge bodies or damage the RBC membrane, leading to hemolysis. Glucose 6-phosphate deficiency is an X-linked deficiency which affects more than 400 million people worldwide. It is the most frequent disease involving enzyme of the hexose monophosphate pathway and is responsible for two clinical symptoms: episodic acute hemolytic anemia and chronic non-spherocytic hemolytic anemia. The most common presentations are neonatal jaundice and episodic acute hemolytic anemia. Which is induced by infection, ingestion of certain drugs like sulfonamides, pamaquine, chloroquine, and rarely benzodiazepines. Diagnosis depends on directly or indirectly demonstration of reduced G6PD enzyme activity in the RBC. Test for G6PD deficiency. Bernstein method. Draw fresh whole blood and hemolyze it. To this, add freshly prepared indole-phenol dye, NADP, G6P, and phenylalanine methosulfate. In G6PD deficient individual, it will take more than 2 hours for the dye to become colorless or reduced. Experiment 27. To a test tube containing citrate whole blood sample, add sodium citrate and methyl blue dye. The sodium nitrate changes the color of the blood to brown. This is because of the conversion of hemoglobin Fe2 plus to hemoglobin Hb Fe3 plus. If the G6PD level is normal in the RBC, then the NADPH present in the presence of methylene blue converts the Hb Fe3 plus back to Hb Fe2 plus. If G6PD is deficient, then the brown color will persist for a long time. Mucopolysaccharidosis. Mucopolysaccharidosis (MPS) are a group of inherited lysosomal storage disorder. Inside the cell, lysosomes function as a primary digestive unit, digesting, breaking down certain carbohydrates and fats. All of the MPS disorder results from deficiency of malfunctions of a specific lysosomal enzyme necessary in the breaking down of dermatan sulfates, heparan sulfates, or keratin sulfates, either alone or together. Failure to break down these mucopolysaccharides results in their accumulation in cells, tissues, and organs throughout the body. All of these disorders are inherited as autosomal recessive trait except for Hunter syndrome, which is an X-linked recessive trait. Test for mucopolysaccharides. Alcian blue spot test. 10 ml of urine is allowed to soak onto a filter paper, after which it is left to dry. After it is completely dry, add Alcian blue, allow it to remain for some time. Now rinse the filter paper carefully in distilled water and then wash with glacial acetic acid, and again followed by a wash with distilled water. The presence of blue spot on the filter paper indicates that mucopolysaccharides are present in the urine sample. Sittler trimethyl ammonium bromide test. See tab. Add 6 drops of cetyl trimethyl ammonium bromide reagent to 1 ml of clear urine at room temperature and mix. The appearance of a cloudy or flocculent precipitate within 20 to 30 minutes indicates a positive test. Galactosemia. Galactosemia is a rare hereditary disorder of carbohydrate metabolism that affects the body's ability to convert galactose to glucose. Galactosemia is an autosomal recessive genetic disorder. Type 1 or classical galactosemia is caused by deficiency of enzyme galactose 1 phosphate uridylyl transferase. Type 2 galactosemia is due to deficiency of galactokinase enzyme, and type 3 is due to type 2 galactosemia is due to deficiency of galactokinase enzyme, and type 3 is due to deficiency of UDP galactose 4 epimerase enzyme. If left undetected and untreated, galactosemia causes profound intellectual disability, liver failure, cataract, and death in the newborn period. Tests for galactose. Benedict test. Experiment number 13. 5 ml of Benedict reagent, add a drop of urine, mix and boil it for not to less than 2 minutes. The presence of a reddish brown color indicates a positive reaction. The test indicates that reducing sugar may be present in the urine. Mucic acid test. To 25 ml of urine in a beaker, add 5 ml of concentrated HNO3, heat and mixture gently to reduce the volume to approximately 5 ml. Allow it to cool. If galactose and lactose are present, then crystal of mucic acid will be seen. Experiment number 32. Methylamine test. To a beaker containing 1 ml of methylamine hydrochloride solution, add 5 ml of urine and 2 ml of 20% NaOH. A red color will be seen, showing the presence of galactose. Mix and heat it at 56 degrees Celsius for 30 minutes and then allow it to cool to room temperature. Yellow color will be seen. Experiment number 33. Barford test. To 1 ml of urine in a test tube, add 2 ml of Barford's reagent. Mix and boil this mixture for 1 minute. A reddish precipitate will be observed sticking to the slide of the test tube. Since Barfords give a positive test with monosaccharides, therefore it points us towards galactose. Okay, now chapter 4 comes. थैंक यू. ये अगले चैप्टर में हम लोग अगले वीडियो में इस चैप्टर को कवर करेंगे. बाय. हंसते रहिए, मुस्कुराते रहिए और पढ़ाई का आनंद लेते रहिए. ओके, बाय.